Assalamu alaikum dear doctor. In this video I am discussing about IDDM, insulin dependent diabetes mellitus history. So first we notice the differential diagnosis of poor control of insulin dependent diabetes mellitus hyperglycemia. So first one is poor compliance. Poor compliance, that is short plus minus thin, either there is insulin therapy, dosage problem, site of injection and storage of insulin. Diet control, that is high calories and less exercise, sedentary lifestyle. These are including poor compliance. Now hypothyroidism, that is presentation short plus obesity, celiac disease presentation short plus thin, and Addison disease, infection, recurrent UTI and otitis media. Then Down phenomenon. This including morning hyperglycemia coinciding with growth hormone secretion treated by increased bedtime insulin. Somoegi phenomenon, that is morning hyperglycemia in well-controlled children, HbA1c and RBS record were good due to nighttime hypoglycemia due to hormonal compensatory, treated by reduced bedtime insulin. Now diabetic dwarfism, that is called Merrick syndrome, short plus obesity plus hepatomegaly. So Merrick syndrome, that is diabetic dwarfism, and presentation is short plus obesity plus hepatomegaly. Social problem like parental conflict, divorce, stress, poor understanding of disease, ignorance and psychological effects of diabetes. So this is the list of DD of poor control of insulin dependent diabetes mellitus. Now what are the complications of diabetes mellitus? We know that is macrovascular, microvascular and others. So microvascular complication of diabetes mellitus is retinopathy, neuropathy and nephropathy. And macrovascular complications including coronary atherosclerosis, peripheral vascular disease and others is limited joint mobility. What to ask in diabetes mellitus? So when we take diabetes mellitus history, what we will ask? We know the history of presenting illness of diabetes patient is polyuria, polydipsia, reduced weight and increased appetite. Renal system for both present complaint and complications. So the renal system amount, frequency, color, flank pain, radiation, character and severity. Growth for both present complaint and celiac or hypothyroidism. Is it significant? How much? In which period? What about her appetite? So first we analyze the present illness of the patient. What is patient presenting diabetes mellitus features and associated with any complication or disease. Next is systemic review. So systemic review, we will looking for symptoms of hypothyroidism, celiac and complications. Number 1 is symptoms of hypothyroidism, that including less activity, constipation, intolerant cold more than others, start to gain weight recently and school performance deteriorate. These are the features of hypothyroidism, we exclude. Next, symptoms of celiac disease, that is presentation weight loss, fatigue and diarrhea. We know that celiac disease, that is diarrhea, difficult to flush the stool, that is presentation. Number 3, symptoms of complications related to CVS, CNS, eye and musculoskeletal system. General question we ask, what about activity? Type of exercise. Time of exercise associated with hypoglycemia. There is any precaution before going to exercise associated with fever, tolerance of cold. What about his sleeping? Now GIT questions, that including what about the appetite? What about bowel habit? Loose motions, if present, then the amount, color, mucus or blood difficult to flush for celiac disease we will ask. If patient presents with constipation, that what mean by constipation? Frequency, 3 to 4 days, consistency, is it solid, any blood, any treatment given and its response, for excluding hypothyroidism. Then any increase in tummy size, hepatomegaly, we know that Merrick syndrome, we exclude. Abdominal pain, if present, we will ask about the site, duration, character, radiation, aggravating and relieving factor of the abdominal pain, and also vomiting we'll ask. From CBS, we'll ask awareness of heartbeat, sudden or gradual. CNS, we'll ask any loss of consciousness, syncope. For Addison disease, we'll ask this, and any headache, numbness, burning sensation of the limb. Then I will ask any concern regarding vision. Respiratory system, we will ask associated with cough. If present, then duration, day or night, dry or productive, difficult of breathing in rest or exercise. Day or night, difficult of breathing, and musical sign present or not, associated with chest pain or not, we will ask. Then musculoskeletal system. Looking for association and complication from musculoskeletal system, we will ask any skin changes, dry skin, skin rash, pigment tone, that is candida, vitiligo or Addison, skin or nail infections. Then we will ask joint pain or swelling, any limitation of the movement, any backache, diabetic arthropathy, any swelling in the skin, looking for atrophic changes of the insulin, any neck swelling or hoarseness of voice, dysphagia and thyroid problem. Now from the growth history we will take. Growth history will ask growth, that any concern regarding his growth, and weight we will ask any change in his weight recently when discovered. Seek any medical advice for weight loss. Type of advice: NG tube feeding, response of interventions, dietitian plan, and follow-up growth chart. Now, nutritional history will ask: seek for compliance of the food. Is he breastfeed, protective, or formula, and increase risk? What type of meal, how many meal or snack, any dietitian involved or not. Next, past history. So past history of diabetes mellitus we will ask: when, where, by whom, and how present. So when diagnosed, where diagnosis, by whom doctor is diagnosed, and how present. How diagnosed, hospitalized or not during diagnosed, how treated, number of any diabetic ketoacidosis and hypoglycemia present or not. Follow up: any indicator of control, looking for complication and associated autoimmune. Regular follow up or not, have any diary or not, who follow, what they did in follow up, like weight and height measure, HbA1c, thyroid function test, urine analysis for proteinuria, for nephropathy, and vision or follow up retinopathy. Now, drug history: seek for the compliance of drug. So, drug history will ask what type of insulin you are using, doses of insulin, any recent change in dose or type of insulin, who given, time of given insulin, storage of insulin, complication of insulin, like is he develop any changes at the site of injection, is the site changeable every 3 weeks, last HbA1c, diary of blood sugars, frequency of glycosuria, if hypothyroid, thyroxine tablet, dose and side effects will exclude. Now, complete the past history by number of hospital admission, where, PICU or ward, and for what, previous hypoglycemia present or not. If hypoglycemia, then when discovered, morning, afternoon, or night, especially nocturnal. What happened as consequences of the hypoglycemia? Is that there is any loss of consciousness, seizure, or any sweating, or only sweating and palpitation? And how manipulate that hypoglycemia? Is receiving sweet, fruits, glucagon or not, shifted to the hospital or not, admitted or not. Previous diabetic ketoacidosis and admissions, only history of anemia, pernicious anemia. History of blood transfusion present or not, any history of surgical operation present or not. Now, neonatal history will ask about any concern regarding pregnancy, delivery, and after delivery. Vaccination history will ask any concern regarding his vaccinations, routine or extra vaccine taken or not. Developmental history will ask any concern regarding his development. Pubertal history will take if the child is teenager, and menstrual history for girls. Family history will ask. So family history will ask of diabetes mellitus type 1 or type 2 present or not, any hypothyroidism, celiac disease, Addison disease, vitiligo, renal disease, anemia present or not. Is your husband or your relative have any diabetic disease or not? How many children you have? So we will ask the family history. Then social history. For social history, we will ask impact of the disease on family, frequent admission, action plan of family, impact of the disease on patient, impact of the disease on school. Is he days missing, insulin in school, diet in school, friends, any bullying at school, role of school nurse and teachers, action plan of school when hypo occur, any social support, finance and health insurance we will ask, and smoking present or not. Now, this is the full history of insulin-dependent diabetes mellitus. Now, the discussions. So, first we will know what is the definition of diabetes mellitus, non-ketotic. So, elevated blood glucose with no ketonuria or blood ketones. Symptoms plus RBS more than 11 millimole per liter, or symptoms plus fasting plasma glucose more than 7 millimole per liter or equal 7. RBS more than or equal 11 millimole meter on 2 tests on 2 separate days without symptoms, and fasting blood sugar more than or equal 7 millimole per liter on 2 tests or on 2 separate days without symptoms. So this is the definition of diabetes mellitus non-ketotic. Now, definition of DKA. Symptoms of diabetic ketoacidosis including weight loss, thirst, polyuria, abdominal pain or vomiting, tachypnea, signing respiration, that is casmol breathing, odor of ketones, dehydration, drowsiness, coma. Plus these symptoms, the biochemical signs also present in diabetic ketoacidosis. These are ketone in urine and blood, blood glucose more than 11 millimole per liter, and acidemia, pH less than 7.3. What are the investigation we normally do for diabetes mellitus? First of all, number 1, to all cases, new and known cases. CVC, RBS, HbA1c, blood gas. Side effects, we will do renal function test and liver function test, blood ketones, urine for ketones, culture sensitivity, and microalbuminemia. These are the to all cases of diabetes mellitus we do. Now, number 2, investigation to newly diagnosed. For newly diagnosed, we do thyroid function test, TSH, T3 and T4, insulin level and C-peptide level, thyroid and celiac antibody test, islet cell antibodies, GAD antibodies, and immunoglobulin A. Now, what is your treatment plan? So, treatment plan is including multidisciplinary team. We involve pediatrician, endocrinologist, dietitian to manage her main problem, nephrologist to manage renal problem. Social service is very important because of family circumstances. Role of social worker in hospital. Psychologist to support her and manage her depression at home, school with her peers. Three important principles of psychologists are staying involved, expressing understanding, and working as team. Ophthalmologist for vision follow-up and liaison between the school and home. Senior teacher should know about the disease and to help patient. Now, different regimen of insulin. These are twice daily most common. Split or mixed regimen, 2 by 3 or 1 by 3 rule. 2 by 3 intermediate acting zinc plus 1/3 short acting regimen. Twice daily with additional short or ultra short. Basal bolus second common, 3 per meal short or ultra short plus longer in evening. Glargine. Then premixed biphasic insulin for non-compliance and insulin pumps. These are the different regimens of insulin. Types of insulin. What are the types of insulin? We know that rapid acting insulin or ultra short acting. So rapid acting insulin, these are Lispro, Aspart, Glucin and Epidra. Short acting insulin, that is regular and soluble, and intermediate acting insulin is isofen insulin, zinc. Long acting insulin, basal insulin, Glargine, Lantus or Determid, and biphasic insulin. Type of insulin, onset, peak effect and total durations. So rapid acting insulin, that is 10-minute onset and peak effect 1 hours, total duration 3 to 6 hours. Short acting insulin, onset is 30 minutes and peak effect 2 to 5 hours and total duration 6 to 8 hours. Intermediate insulin is 2-hour onset and peak effect 6 to 8 hours and total duration is 16 hours. Long acting Glargine, that is onset 2 to 4 hours, peak effect is peakless and total duration 20 to 24 hours. Biphasic insulin, onset is 30 minutes, peak effect is 1 to 12 hours and total duration 16 to 24. Now, emergency management of hypoglycemia. When a patient has emergency management of hypoglycemia, what we do? If RBS is less than 2.6 millimole per liter and Glasgow Coma scale is less than 8, IM glucagon injection and seek for help. IV access. Take sample for investigation. IV bolus 10% and maintains recheck if still low RBS. IV hydrocortisone 4 mg per kg. Then hydrocortisone infusion. Then increase the glucose content to 14 to 20%. Consider octreotide diazoxide glucagon hyperinsulinism if glucose load more than 10 mg per kg per minute. If RBS is less than 2.6 millimole per liter and contrast GCS more than 8 and well, then immediate feeding and recheck after 10 minutes. Now, treatment of diabetic ketoacidosis. The patient present with the clinical features of diabetic ketoacidosis, first we admit the patient. Admission. IBF according to level of dehydration plus potassium chloride. So, intravenous fluid we will give. Insulin infusion 0.05 to 0.1 unit per kg per hour after first hour of fluids. Correction of the acid-base balance. Monitoring of RBS, neurological status and side effects. How follow and monitoring of diabetes. So, we monitor the diabetes at time of diagnosis, HbA1c every 3 to 4 months, thyroid disease at diagnosis and yearly, celiac disease at diagnosis and every 3 to 5 years. Once a year, we do the diabetic patient blood pressure, microalbuminuria and retinopathy annually from age of 12 years, thyroid disease and review food care. At every clinic visit, every 3 to 4 months, we do height and weight, HbA1c, check injection site. What is glycemic index? So, glycemic index is this, measures how rapidly a food stuff can raise the blood sugar in the blood. What is the risk sick day in insulin dependent diabetes mellitus intercurrent illness? So, if no vomiting, check RBS every 2 hours. If RBS above 15 millimole per liter equal 270 milligram per deciliter, then check for ketonuria, avoidance of carbohydrates, 20% state dose of total insulin requirement as short acting insulin every 6 hours and stop longer acting insulin temporarily. So, if no vomiting and the RBS every 2 hours, we will check. If more than 15 millimole per liter or 270 milligram per deciliter, then we will take these steps. Now, if vomiting or ketonuria presents on diabetic patient, RBS hourly admission to the hospital may be appropriate. Now, they are telling sick. Easy to remember. S for sugar, I for insulin, C for carbs, and K for ketone. So, S for sugar. Check your blood glucose level every 2 to 3 hours necessary, even more frequently for pregnant women and children. I for insulin. Always continue to take your insulin even when you are sick to avoid DKA. Next one, C for carbohydrates. Make sure you take in enough carbs and drink enough fluid. If your glucose level is high, stick with sugar-free drinks. If your glucose level is low, drink carb-containing drinks. Now, K for ketones. So check your blood or urine ketones levels every 4 hours. Take rapid-acting insulin if ketones are present. Remember to drink plenty of water to flush out the ketones out of your system. So this is all about the insulin dependent diabetes mellitus history and discussions. Thank you.